Okay, so now we're going on to question number 2. Guys, if you've got any doubts, please feel free to approach me anytime during the class. I have no problems in answering your questions there and then. This way it feels more interactive, and I'll keep asking questions no matter what. Okay, there have been the exams of my students ongoing, and today is their last paper. So question papers are coming very on the similar pattern, but of course there are some googly questions coming in as well. So I think you should all look at their paper as well. If you want, I can share those question papers, the kind I have with me. So the recalls and questions that I have with me, I can share with you, and you can also prepare that paper as well. So that paper classes I've taken last month, in fact. So those 4 weeks I've already taken papers of the main batch, and you should all go and see those questions as well. I don't think they'll ask you a similar question, but similar topics can come. Okay, all right. So now there was a question on hormonal changes in menopause. See, this is also a repeat question. Okay, hormonal changes in menopause. I've already made this answer before. There is estrogen decline, one of the primary hormones. It declines. Everything actually declines over. Estrogen decline is there. Then progesterone reduction is there. Okay, and it has its after effects. Okay, I'll tell you how. Then FSH, LH, they increase. Okay, so what is decreasing? Estrogen, progesterone, and FSH and LH is also actually increasing. Why are they increasing? Because of the HPO axis I just spoke to you about. Then what happens to testosterone and DHA? Can anyone tell me quickly? What happens to testosterone and what happens to DHA? And why don't we require them? Please, guys, quickly, come on. Let me hear how many of them are there. Yes, Angel, I think you're very interactive. You can let me know. Arthur is also there. That's great. Yes. What happens to the androgen levels? Come on. I'm waiting. And we don't make me wait so much because it all comes in the recording. All right. Okay. So since I've got your mental clock ticking, my purpose here is done. Yes, testosterone declines. And why do we require testosterone? Why do we need that in the old age? Why? The most important, you'll be surprised to know, is this. It loses the muscle mass. A big reason why there is a, you see the muscle mass going down in elderly females is the loss of testosterone. Libido, very important aspect. It decreases the libido. And as far as DHEA is concerned, well, that is basically primarily by the adrenal glands, okay? And it's a precursor of testosterone and estrogen. Yes, so you have a decline in this as well. Okay, right. So see, the question was hormonal changes, all right? But I have added this because they can ask you the various signs and symptoms of menopause. So vasomotor symptoms, mood and cognitive changes, urogenital symptoms, sexual dysfunction, bone and cardiovascular health, then long-term health problems like cardiovascular, osteoporosis, cognitive decline. And this I have added as a nice slide that I saw, which is like in just one, just you can see osteoporosis, because the next question is on osteoporosis, the diagnosis and the management. Yeah, the question was on diagnosis and management. So, well, you can diagnose it through this bone mineral density or this one should be the answer. Dual energy X-ray absorption, the DEXA scan you must have heard about, right? So DEXA scan, very good, Angel, very good. See, this is the energy I like, okay? So keep answering. It will just make you remember what you heard in the class is what I'm saying. You don't have another one, In fact, if I'm a student and if the most boring thing is, to go through these slides, unending long list of slides, 117 slides or so I've made, okay, without, a group to be with. So this is different energy altogether. All of you utilize this time, right? So keep answering so that you remember at least, let's say, 50 to 60% of the class. Everything you already know. It's just a revision, okay? So just listen up and answer. And you will remember this class, I'm sure. And then only 40% more you have. Right. Some of you can even do 70%, I'm pretty sure. So the diagnosis comes through dual X-ray absorptiometry, okay? And you have T-score of what is this? Defines this with a BMI, that is 2.5 standard deviation or more. This is what I was thinking. How can it be less? Below the mean for a young adult. So what you're doing is actually, this reference is with the normal young adult. For children, you have a different BMD. But for adults, you go for dual X-ray, dual energy X-ray absorptiometer, DEXA scan, and you score T2.5 and more as the young adult reference population, and this is considered as osteoporotic. There's also osteopenia in this score, right? But mostly this test is recommended for postmenopausal women, aged more than 65, men more than 70, and younger postmenopausal, yes, the younger females who are having risk of fracture. So like I just told you, if somebody had a, let's say menopause, or let's say POI at 38, and now she's not having menses, her bone mass is going to be the level of osteoporosis at the age of 50. When 50, there are certain people who still not having menopause at 50. So they will have this problem in 70 years. So she's far more at risk. Now, talking about osteoporosis, there are certain non-pharmacological methods which I would like to start first. For example, lifestyle change, change in nutrition, change in diet, change in exercise, and basically most of strength building exercises, right? More than running and jogging, and yoga is also very good because it's kind of a strength building exercise, improves the stretchability, flexibility, but more than flexibility, and more focusing on the strength of the patient. So yes, diet and nutrition, lifestyle changes, exercise, smoking cessation, very important, alcohol moderation, and fall prevention, of course, is very important. When it comes to pharmacological treatment, then you have bisphosphonates is very important. So these are anti-resorptive agents. They work by slowing down the process of bone resorption. So bisphosphonates like alendronate, risedronate, ibandronate. Wait, I'll take a different color. Yeah, and zoledronic acid, sorry. And these are actually, they reduce the bone turnover. Okay, they inhibit the osteoclastic activity. This is also asked. Okay, just the mechanism of action of bisphosphonates or the pharmacological management of osteoporosis has been asked. It has been asked. See, HMB. I'm sorry, the menopause has been asked in various different ways. Okay, just the osteoporosis has been asked, like it has been asked here. Just the pharmacological management of osteoporosis has been asked. The hormonal changes has been asked. The second time it was asked. Then the signs and symptoms, or the change, biochemical changes, or I don't know, something like that, with symptoms in the perimenopausal and menopausal age. Both were asked. Okay, I think straw classification also they've asked once. I don't remember exactly, but yes, these things are asked. Now, so there are side effects which I've mentioned. I've mentioned the name. I've told you what do these bisphosphonates they do. This is a very important part. You should remember this. Then you have something called as denosumab. By the name, what do you understand of it? It's a kind of an antibody, right? So it's a monoclonal antibody, and this inhibits the rank ligand. Very important. Just remember to read it once. Okay, a protein essential for the formation and function of osteoclasts. Now, it has its own side effects, but these are anti-resorptive agents, correct? Then you have anabolic agents. Teriparatide, romosozumab, these are all anabolic agents. Basically, they do what? This is a recombinant form of PTH. So, it increases the bone formation by stimulating the osteoblasts, correct? And what about romosozumab? This is an anabolic, a newer anabolic agent that inhibits the sclerostin, a protein that inhibits the bone formation. Inhibits the bone formation. It's inhibiting the inhibitor, correct? Its name is romosozumab. Please remember these things, guys. Make your own funda. Teriparatide, its a name suggests it's one of the recombinant forms of You must have heard about this thing before. The parathyroid hormone also has its recombinant forms, okay? And one of them is teriparatide. This is an older drug. But romosozumab and even this denosumab, these are newer agents. One of them is an anti-resorptive agent, and this is an anabolic agent, romosozumab, right? And of course, HRT plays a very important role in preventing osteoporosis, and even SERMs they do. right? Because it reduces the risk of mostly vertebral fractures and femur fractures, right? And of course, prevention of fall is very, very important. This is one of the primary care methods. Then you have the management, you have the follow-up, you have to get done a DEXA scan annually, okay? You have to monitor the side effects because they can have jaw necrosis and femoral fractures, a very typical side effect of bisphosphonates, yes. And you have to keep checking the calcium and vitamin D levels. Now you have so many tests designed to test that, right?